Thank you so much for the opportunity to share some data from the hepatitis elimination profiles, and just want to start with a thank you to the many contributors to the profiles that are around the room, and it's been very nice to see many of you here. These are my disclosures for funding to the Coalition for Global Hepatitis Elimination. And just to start with, the Hepatitis Elimination Profile Initiative was launched in 2021 by the Coalition to help bring together the different sources of data that are available on hepatitis elimination: burden of disease information, progress towards WHO goals, implementation of interventions, and then also put forth a more detailed assessment of the policy environment for hepatitis B and C elimination that we felt was lacking at the time. And so these profiles are meant to be comprehensive resources that bring together the different sources of data available and help to identify challenges, but also achievements and next steps for each country to pursue. The profiles are developed in collaboration with Ministry of Health officials, clinicians, civil society across the countries and territories. A standard data collection tool was developed at the onset of the project based on WHO program planning and the GHS strategy document. Today I'm going to share some data from the profiles on screening and treatment policy trends around the world and in Asia. Also looking at policy scoring, bringing together both the screening and treatment policies, but with also the policies on strategic information, equity, and financing across the policies to look at how countries compare. And lastly, looking at where we are in terms of progress towards elimination based on the profile data. At the time of submitting this abstract, we had 33 profiles available across the world. This data was actually summarized in May in Lancet GastroHep publications, where we refer to them as the global reports. So today I'll be talking about 38 profiles. Those original 33 plus 5 more published this summer. These new ones include Romania, Poland, Moldova, Uzbekistan, and Cambodia. And the full list of countries of profiles available is here and shaded in the teal color. So to jump right in on policy trends, when we look at screening recommendations on who to treat globally, we're seeing a greater movement towards expanded screening recommendations, which is really exciting, highlighted and featured here in this conference by the Korea New Policy. So for hepatitis C, we're at about a third of the profile countries having universal or one-time screening policies, and then we have about 15% of countries having age-based or birth cohort policies. For hepatitis B, a slightly lower proportion have universal policies at about a quarter of the profiled countries, and a similar proportion have age-based or birth cohort strategies. Looking at a specific population in pregnant persons, it's probably not surprising that the majority of countries globally have policies for screening pregnant women for hepatitis B, but importantly for hepatitis C, it's less than 60% of the profiled countries, so this is a gap we'd like to highlight. In terms of affordability and decentralization of testing and treatment for hepatitis B, the profiles show that across the 38 countries, only about a half have removed co-payments for testing and treatment of hepatitis B. And only about half have introduced point-of-care PCR testing, a technology we know to be effective in improving uptake of testing and linkage to care. In terms of decentralization, about half of countries have also allowed decentralization of primary care providers and non-specialists to manage hepatitis B and hepatitis C, but this percentage is slightly higher for hepatitis C, about 60% of the profiled countries, and lower for hepatitis B at only about 40%. So when we take a deep dive in Asia, the next 4 slides will look at hepatitis B and hepatitis C decentralization and access policies that we just went over globally for a subset of upper middle income and high income countries and lower middle income countries across Asia, 13 in total. For the 6 lower middle income countries, 2 have expanded hepatitis B screening strategies, but only 1 has removed co-payments for testing in the public sector, and none have removed co-payments for treatment in the public sector. Only 2 of these countries have policies to decentralize hepatitis B management to primary care. For high and upper middle income countries, of the 7, 4 have expanded strategies for hepatitis B, and all have one, but one have removed testing co-payments, but 4 of 7 have removed treatment co-payments. None have point-of-care PCR testing, and 5 of the 7 have policies for decentralizing hepatitis B treatment. Moving to hepatitis C, in the 6 lower middle income countries, only 2 have expanded hepatitis C screening strategies. Only 1 has fully removed co-payments for testing and treatment in the public sector. And 4 of the 6, though, have approved point-of-care PCR testing, likely building on HIV and TB investments from the Global Fund. And 4 of 6 allow non-specialists to treat hepatitis C. In high and upper middle income countries, a greater proportion have expanded testing for hepatitis C. 4 have removed co-payments for testing, 3 for treatment, 3 have approved point-of-care PCR testing, so more than for hepatitis B, and all but 1 allow non-specialists to manage hepatitis C treatment. So when we bring these testing and treatment policies together with the other policies in the profiles, strategic information, equity, financing, and prevention, we're able to calculate a total score of how many policies the countries have adopted compared to the others. For hepatitis C, the maximum score is 26, but there's a broad distribution across the 38 profiled countries. The highest score is 23 out of 26 in Spain and Uzbekistan, but closely followed by Australia at 22, and the lowest score is 9 in Bangladesh. We want to highlight, though, that we found in the global reports, originally looking at the 33 countries, that there is a significant association between policy score overall and income level of the countries. So the average policy score for hepatitis C in high-income countries was 19.5, in lower and middle-income countries it was 15.5, and upper middle-income countries 17.5. And if you look at the color of the bars and then the purple circles on the top represent the Asian countries, you can follow along and see within Asia a similar trend can be observed across high-income countries having higher scores. For hepatitis B scores ranged out from 20.5 out of 21, highest scores in Rwanda, but closely followed by Taiwan and Australia, with the lowest score again in Bangladesh, and a similar trend and association between income and total policy score. So lastly, looking at how does the policy scores and policy adoption compare to actual progress towards the WHO targets? So when we look at the diagnosis target for the income target, starting with the 2025, 8 of the 38 countries have met the hepatitis B target, so about 1 in 5 for hepatitis C. 10 of the 38 have about 1 in 4. And of the 8 that have met the hepatitis B diagnosis target, half are in Asia. And for hepatitis C, 4 of the 10 are in Asia. So bravo to our Asian colleagues here today. And then for treatment, an important finding of the global report was that no countries have met the 2025 target for hepatitis B treatment. 5 had met that 25 target for C, and of those 5, 2 are in Asia. Looking at the ultimate elimination goals related to mortality, we didn't have enough data to look at the incidence targets from WHO, but we see that 14 of the 38 countries have met that 2025 target for hepatitis C mortality of less than 3 per 100,000, and 7 of those 14 of the 38 have met the target of 2. Of the 14, we had 4 in Asia, which are listed on the right. And of note, Korea has also provisionally met that 2030 target of 2 per 100,000, as we saw in the previous session, slightly on the border of 2 per 100,000. I think she showed 2.02. For hepatitis B, 20 countries and territories have met that 2025 interim target for 7 per 100,000 mortality rate. This is due to the large advancements we've seen in infant vaccination globally. And of those 16 have also met the 2030 target of 4 per 100,000. In Asia, we don't see as many of the 20 listed here. 3 have met that less than 7, and 2 of the 3 have met the less than 4. So lastly, I just want to mention this path to elimination framework from WHO. We're working on incorporating this into the profiles, but if you break down the path to elimination framework, which is a new tool for WHO to track progress, this is 3 of the 5 or 6 criteria or so, and we can see that countries around the world have met different criteria. And so we hope that by showing countries where they are on potentially meeting 2 of the 4 bronze or 2 of the 4 silver, 2 of the 4 gold, countries can be inspired to improve their coverage in the other areas and apply to be validated like Egypt has for gold. So thank you so much for your attention. I think I'm at time, but just to conclude here, countries are making progress towards these elimination goals, and we should celebrate those achievements, recognize those gaps, and help all countries continue to move forward. So thank you so much to all the hepatitis elimination profile contributors, and a small plug at the end here for a survey on multiplex testing to inform WHO guidelines. Thank you so much.